Good morning, good afternoon. Welcome. I'm David Willis. I'm the founder and director of Nurture Connection, and we're delighted that you're joining us today for this amazing conversation with two dear friends of mine, R.J. Gillespie and Amy King, and we're going to talk about their book, The Trauma-Informed Pediatric Practice, a resiliency-based roadmap to foster early relational health. But before we get started, it might be valuable if you would please put your name if you'd like and where you're from in the chat, as well as maybe answering one question about how are you doing today, answering with one word. And then we'll encourage you to put questions in the chat or in the question comments, so then we'll attend to those as we go forward. But let's get started. I want to tell you first about Nurture Connection. And Nurture Connection is a national field catalyst and impact network committed to promoting early relational health through strong, positive, and nurturing early relationships. Community by community, we're building a network and engaged initiative in partnership with parents and families. Over the past 5 years, in partnership with the Center for the Study of Social Policy, we've brought together parents, caregivers, researchers, medical professionals, philanthropists, early childhood leaders, and policymakers to strengthen families focused on this relational health space. As was in this fall, it was very exciting that we now anchor ourselves with Georgetown University's newly established Thrive Center for Children, Families, and Communities. The Thrive Center is a large, multidisciplinary, innovative center designed to rapidly advance equitable systems of care and supports that enable children, families, and communities to thrive. Nurture Connection, now joining the Georgetown Center, is excited because the Georgetown Center has a deep and ongoing commitment to advancing early childhood field and the institution's partnership with innovators, leaders, and organizations, and we're thrilled to be a part of that work. You can learn about all of our work and the evolution of the Nurture Connection space by joining our network at our website, and which will allow you then to receive a monthly newsletter and blogs that we continue to create as we build this movement around us. So let me tell you about Amy and RJ. First of all, I'm so thrilled to have my longtime friends from Oregon joining us today to speak about their recently released book and the wisdom and the experience that they've developed from clinical practice and action that's gone from trauma-informed care toward early relational health promotion, prevention, and healing activities. I've known each of them, and as I've read the book, it was joy to know of their own personal journeys about how they've moved from research to proactively learning, and then also how they share their reflections together as to how they each together had clinical experiences that they share, as well as helping to describe their own personal experience of learning and partnering with families along this learning journey. It's really remarkable as a framework of really advancing new age practice for pediatrics. They focused a lot on relational history taking, empathic listening, guidance in support of families' growth, families' healings, and resilience. And all of these, I would suggest, are critical skills now for current pediatricians and especially next generation pediatricians and residents. Let me tell you about each of them. R.J. Gillespie is a general pediatrician at the Children's Clinic in Portland. He also worked as a medical director for Quality Improvement, Children's Health Alliance. He was the founding medical director of the Oregon Pediatric Improvement Partnership. He's conducted research around adverse childhood experiences, done training and consultation in screening and referral, and has been active in a number of national advisory committees within the AAP, helped shape the project called ASHU, which was addressing social health and early childhood wellness efforts. He attended medical school at OHSU. His residency was chief residency was at Rush Children's Hospital in Chicago, and he earned a master's degree in health professional education from the University of Illinois in Chicago. He's been a national leader in trauma-informed care, but now relational health and helping practices transform the way they see and work in this space. One thing you know about that you tell who RJ is by his dedication in the book. And I'll quote, "To you, my colleagues in the trenches, may this strengthen and support you as you give your hearts and souls to the care of patients, your patients and families." It just tells you of the heart, style, and soul of who RJ is. Similarly, Amy King is a licensed psychologist who provides training, consultation, and education to professionals and organizations. She specializes in trauma-informed work and resiliency building. She advises organizations around wellness, staff vitality, creating trauma-responsive spaces. Her specialties include working with professionals to create resilient children, families, and thriving families. She works as a statewide and national trainer for various organizations. Her work has been promoting relational health by training professionals who work with children and families through partnership and collaboration. And when she's not doing all this good work, you can find her with her family in the beautiful hills outside of Newburgh, Oregon, with her small hobby farm. So, and similarly to RJ, in her dedication, she says within this book, to the children and families that have allowed me the honor of hearing their stories, thank you for being the most amazing teachers. I hold your stories in my heart. It's with great pleasure that I welcome RJ and Amy. And let us first begin. Welcome, both of you. So the first thing I'd love to know is who you are beyond your professional lives. I mean, what's your why? What's your journey that got you here? Then we can talk more specifically. So Amy, do you want to go first?
This is a question I love. I think a lot about my why, and the primary one is that I want less aloneness in this world, and that's really why things get deeply rooted into connection. I feel like it's those relationships that are like an antidote to stress that we experience every day. And so in my 25 plus years of practice, what I notice is when we offer ourselves in relationship to others, it's healing. And I've known that since I was a little girl myself. And maybe we didn't have words for that then, but in psychology, we have this silly phrase that says research is me search. And so definitely it's a process of finding yourself and offering less aloneness to the world.
Phenomenal. And RJ, for you, what's your why? How'd you get here?
You know, I feel like my career has taken a very circuitous path to get me to where I am, and most of my career opportunities have been misunderstandings or accidents for the most part. You know, I got into quality improvement because I had a master's degree, and somebody sitting at a meeting in an independent practice association said to me, "You have a master's, you must know how to do statistics. You should do our quality improvement programs," which, you know, jumping from master's to statistics was kind of a funny thing. But you know, it ended up working for me. But I think from a clinical perspective, I remember very clearly a mom who had a well visit with me, and it was her sixth kid. And when I got to the point of talking about safety and the typical anticipatory guidance, I saw the mom kind of slump back in her chair, and she kind of said, "All right, let's get this over with." And it was at that moment that I really had sort of a lot of clarity, I guess, that we were doing well child care wrong, right? That we were doing this sort of one directional, you do all, you know, all these things that I tell you. Parents weren't really listening to us. And it didn't really feel like a very life-giving experience for me as a clinician either. And so when I started really looking at trauma-informed care, and I think that trauma-informed care training is a little bit misnamed. You know, most, I think, TIC training really is about trauma awareness, right? So it's about talking about like trauma is common. What you're seeing in your office may be related to trauma. Be nicer and be more empathetic. And I think as a clinician, I thought I am nice and I do have empathy for my patients. I want to know what I can do differently for them, and really moving from trauma awareness to trauma responsiveness, and then trauma informedness when we have a practice that fully functions in that space, really is a transformational journey. And if you think about, for us, the difference between a toxic stress and a tolerable stress, as we call it, the primary difference between those two things, the toxic stress being something that overwhelms us and the tolerable stress being something that's survivable, there's one difference between those two, and that's the presence of a safe, stable, nurturing relationship. And I've had patients, when I talk to them about their own trauma history, their comment to me is, I want my relationship with my kid to be as strong as possible. And so then we get into the how how do we do that? And that's really the meat of where I find reward and happiness and satisfaction out of working with my patients, is really helping them to answer that question. How do I strengthen that relationship between my kid and I? And I would say that for me, and I'm going back to my residency training, I had 2 weeks of developmental pediatrics and psychiatry total. And so coming into practice, I was starting from scratch, right? Like all of the behavioral stuff that I was seeing, I needed to learn how to do that. And when we got to the, what do we do differently in practice? That's when I met Amy, and kind of the rest is history, so to speak.
Well, there we go. So I think it first might be valuable for the audience for each of you to describe what this book is about from your own words. And then we can talk more specifically about some particular topic areas. But Amy, how would you describe what this book is about?
Oh, I'm going to try to be as brief as I can be, but I'm going to pick up a little bit where RJ left off, right? Where our paths crossed. And here I was, a psychologist in private practice doing trauma-informed therapy, mostly with kids and families who'd experienced a lot of complex stress and trauma. And then I also had this background in integrated behavioral health and pediatrics. And as providers began reaching out to me when they became more knowledgeable around adverse childhood experiences and the long-term health impacts that could be there, what we knew first is that we can't do anything until we know first, what is the origin? What's happening? How does stress and trauma present? And then the big question became, okay, now we know, what do we do about it? Pediatricians are practical, right? They want to help kids grow and thrive. And so initially, I had an incredible group of pediatricians approach me and say, gosh, we heard about this ACEs study and it doesn't seem like great news. What do we do about it? And that is part of the path that led me to meeting RJ. I saw that there was this champion that was doing ACEs screening and a questionnaire in his practice. And I thought, wow, I've got a like-minded friend here and an ally in this space where we could partner. And I'll let RJ talk about that from his perspective, but we knew that pediatricians wanted to know, what does trauma and stress look like, to not feel overwhelmed by beginning to be curious about it. And then what do we do about it? And really, we couldn't wait to make a roadmap, if you will. And that's why it's called a roadmap to relational health that could get in the hands of providers as soon as possible. We just knew this would be transformative for practice.
Right. And RJ, similarly, how would you describe the book, especially the roadmap concept within it? If you have described that, it'd be great.
Yeah, I think that as pediatricians, and most of us went into pediatrics because we really loved the prevention aspect of the work. And I think that waiting until a trauma has happened to one of our children or our families, the horse is out of the barn. We can repair that without a question, but is there a way to prevent it? And so really the roadmap is taking 100 little conversations that we have over the life of a child and turning those into mini interventions about how we promote relational health. So at each well visit, we have some sort of subject that is developmentally appropriate, that is trauma informed and is resilience building, that we actually use in that visit to help prevent and prevent trauma potentially and promote the relational health, so that if there's a trauma that's unavoidable, and I would say that some of the adverse childhood experiences are probably preventable, and some of them you can't really do a lot about, but if that relationship is strong in the beginning between a caregiver and the child, then you have a better chance of that child recovering from a stressful event. And so at every visit, if we talk about something that helps build relationships, and sometimes that's an independent standalone intervention, and sometimes that's just changing some of our anticipatory guidance. I've always hated the idea that pediatricians are seen as people who just tell you to eat your broccoli, right? Like we have this sort of not super useful way of approaching advice. But if instead we talk about what is your routine around meals, what things do you talk about? That becomes an opportunity to talk about resilience. For example, I always go back to the example of at dinner, my goddaughter's family always talked about highs and lows at every dinner. And so what they were doing, everybody in the family would talk about the best thing and worst thing that happened in their day, which gave the relationship some one-on-one time, some focus, right? But it also let the kids learn about problem solving skills from their parents and learn about how you adjust and adapt to bad things that happen. That's a pretty easy thing to teach, right? And it's going to land better for parents than eat your broccoli, right? So I think that as we go through our well visits, if we transform it that way so that we're building relationships little by little in a way that's developmentally appropriate, that's really what the roadmap is about. Again, as a pediatrician, I'm all about prevention. So I want to really have strong relationships to prevent or mitigate the effects of trauma down the road.
If I can add something too, Dave,
Please.
when we laid out this roadmap in the book, we really have walked through ourselves in practices and with other physician groups, with other providers, the barriers that come up, the hesitation that folks experience when we talk about trauma-informed care, and they think, oh my gosh, I'm adding one more thing and I'm already a busy clinician, or we have a really busy practice. We really do lay out for you and kind of what to do, how to do it, barriers that will crop up, creating those champions, those ambassadors that are in your clinics that are first adopters, and really reframing relational health as trauma-informed response, and allowing folks to see it's not one more thing we're adding. It really is the thing we're doing. It's the lens that we see everything through. To be trauma responsive means to be relational. And I think over and over, what RJ and I see is the more we focus on the relationships, and that might mean in your clinic, right? Not just outward facing, but inward facing too, how we treat each other, how we treat our colleagues, how we treat our staff, and then how we treat patients and families that come in. It really becomes about focus on connection and support.
And part of that, I think, sorry.
RJ, I was going to go back to Amy. You made a comment about you were invited by a group of pediatricians to sort of learn with them and study with them. Can you talk about that journey and how it helped inform what then came further into this roadmap? I'm really curious how, the origin story of your engagement into this space. And then RJ, your own view of that contribution, because it's so dramatic, such an important part of the story.
Yeah, so as I mentioned, a group of pediatricians through the Children's Health Alliance in Portland, Oregon approached me and said, okay, so ACEs are not great, but we want to be proactive. We're taught to be preventative. What do we do about this? And I began meeting with them and I said, I think there's a way we can offer the antidote, right, which is relational health, resilience via relational health. And I will never forget one of the champion physicians there in the room said, okay, well, what I'd really like is somebody to create these doses. So what RJ and I talk about, these 100 small doses. Could you just make like a resilience curriculum for every well child birth to 21 and then tell us how we could become more trauma responsive? And I naively said, sure. And so, we set out to do just that. RJ had done a lot of training with Children's Health Alliance around ACEs and what it meant to be trauma responsive. I built upon that with the relational health piece and providing these little doses of relational health at well child visits. And at first it was just like watching spaghetti stick to the wall. Like pediatricians would come back to me and they're like, I don't know how to talk about this. Am I going to create more trauma by asking about trauma? Like, can I have a different script? And how do I do this in a strength-based way about relationships? And we would just go back and forth, this dynamic interchange. And they would come back and say, that feels really natural for me. I can do that in about 2 minutes. That doesn't feel like more that I'm adding to my plate. And the incredible thing that I began to see is these physicians who were feeling kind of hopeless and despaired about the ACEs research. As they began to focus on relationships and relational health and resilience, they began feeling less burned out, more confident, more competent. Their relationship with their patients began to change. they just began to feel more purposeful in this work. And so it was just an incredible start to shifting the focus from, as we know now as the new AAP statement of policy, shifting from assessing adversity to really building the buffering mechanisms. And it felt so natural to what they were already doing.
What would you add, RJ, to that kind of what it did to you or your colleagues, or how the
Yeah, I
mindset?
think,
And
yeah,
go ahead.
absolutely. I think that from where I started in screening, we started working on developmental screening way back in 2007, followed by maternal depression screening. Later, we've had requirements around social drivers of health screening. We've had requirements around social emotional health screening. And I think that to a non-trauma informed practice, that looks like a lot of independent data points, right? Like we kind of get this screening tool, we look at it, we say pass or fail, we do our referral, we move on. And really what trauma-informed care teaches us to do is to look at those as a cohesive story, that all of these different things relate to relational health in some way. When we look at maternal depression, when we look at social drivers of health, those are things that turn a caregiver's attention away from their child so that they're not available. And I love Andy Gardner's quote on this, that it's hard to be in relational mode when you're in survival mode. And so that kind of puts a thread through all of these different things that we're doing in practice to give them some relevance and some poignancy so that they're actually part of the big picture. And so Amy and I have talked in the book about a relational health history as being a big part of what we think needs to be done in transforming well care. So, we're used to things like the past medical history and the family history and those sorts of things. The relational health history is really looking at what barriers to relational health are happening to a family and what facilitators as well. And so I sort of paradoxically think about a past, a present, and a future relational health history. So the past would be what happened to the caregiver and their trauma history, what they're bringing into their relationship with their child. The present is sort of the social drivers, maternal depression or caregiver mental health problems. The future is really looking at positive childhood experiences and what we want to promote in our relationships, what we want to have happen for our kids. So setting some intention around creating those strong relationships within a family, within a community, within a school, and so forth. And so, the transformation goes from looking again at these sort of independent, unrelated screening tools into this is what the family looks like, and this is where we need to focus our attention in terms of how we help and support that family. And so that to me is, I think, one of the biggest transformations that I want to see primary care do, is to really integrate all those different things into, these are relational health issues.
RJ, that's phenomenal. What about the family experience? What kind of green lights did you get that taught you that you were on point as you move along this journey of transformation that you've gone through? And now you've codified in the book, but also we're witnessing in our colleagues across the nation. But what was that journey, and how did families help you learn?
Gosh, I mean, there's so many examples that I could think of. There are a couple that stick out though. I mentioned earlier the mom who, when I had talked about her trauma history, and she told me, I just want to see, I want my kids, my relationship with my kid to be as strong as possible. But I remember in particular the mom of a 4-year-old, and she was coming in for behavior concerns. And basically the story was that every time she disciplined her child, he would laugh. And to me, that seems like an innocuous behavior. The kid giggled every time mom tried to do a correction. But as I'm looking at mom, her face is turning really red and the veins are starting to stick out in her neck. And she is really angry about this behavior because it means something different to her than it does to me. And so when I'm doing my best relational health work, I can recognize this is a problem that we can solve by helping reframe what the child is doing behaviorally and give her some tools to work with that. And so I talked to her about, do you think he's giggling because maybe he's embarrassed? And her shoulders dropped and she thought, oh, probably, right? But to her, it sounded like the person who used to verbally humiliate her and verbally abuse her as a kid. And so when we talked through that behavior, and she kind of laughed and she said, great, okay, I'm going to work on that. Her next visit, though, she came in And I had barely said hi. And she said, you know, I'm trying to work on what you just taught me to do last time, but my mom just died. I can't get food on the table, and my husband just lost his job. Can you help with that? And it was at that point that I realized that my practice culture had changed, that I was the safe person to come to with all of those sorts of relational health barriers. And the mom just came in and laid her agenda out. And I was like, how fantastic, you know, because I think that when we go in without that sort of relational lens and that trauma lens, we kind of force our agenda down on somebody who's not ready to hear it because their mind is somewhere else. And once we can get to the point where parents and caregivers can tell us, these are the things that are getting in the way of me having a relationship with my kid, that's magic, right? And so I was able to address those concerns. And honestly, that was all I did that visit, was just give her the resources, help her connect, and really listen, you know, empathetically to where she was. And for me to connect with her helped her to heal and to feel safe coming to me the next time. So that to me was one of the points where I really, again, realized that practice had changed for me in I think, a really profound and positive way.
Amazing. Amy, how about you? What did you witness of the clinics that you've worked with and the physicians you've been involved with about how they grew and how families help shape their experience? What have you witnessed?
Yeah, I think you noticed that RJ and I both share and help others learn by telling story. And I will never forget, I had gone into the Oregon Medical Association and taught a lot of the pediatricians some of these brief interventions that strengthen relational health. And one of them is kind of a reframe about how we identify core feelings that I call yoki feelings, if you will. And it gets into that kind of feeling state that some medical providers aren't always as comfortable with, you know, labeling feelings. But what we know as trauma-informed therapists is that if we can help kids label sad, worried, confused, instead of the anger and the behaviors that often result from anger, hitting, kicking, biting, hurting, we actually know we can reduce things like corporal punishment in caregiving relationships. So I was teaching this little intervention about how to help kids label their feelings. And I could tell that one of the physicians in the room was really disengaging, like, you got to be kidding me. Now I have to talk about feelings on top of everything else. And I just kind of let it go. But a couple of weeks later, I called him because we were consulting about a mutual patient with ADHD. And so I was checking in with him and he said, no. We got to talk about yoki feelings. And I said, what? And he said, yeah, it turns out that at the 6-year well child check, I've done like a lot of kindergarten readiness. I finished like, you know, helmet safety and bicycle safety, but every 6-year-old has behavioral disruption. Every 6-year-old has anger and feelings. And he's like, so I thought, well, I might as well give this a shot. And he said, it has transformed my practice. He said, now my MA just knows that at every 6-year-old well child check, we're talking about feelings, we're learning how to label feelings, and it helps me, the provider, model to that parent how we can do that and make it look easy and accessible. And then the parent can take that home. And so those are the types of stories that I notice that are just transforming it. It can be small, it doesn't have to take a lot of time. But the dose response in terms of the outcome for the child and the family is such a high yield.
Phenomenal. That's great. There's some questions coming in. I'm going to go to the question box for a few. Ann Stone is listening in. Hello, Ann. And she says, hi, RJ. Do you intentionally think about fatherhood involvement in your relational health history? And does your practice attempt to engage the non-presenting parent in that kind of work?
That's always a tough one, you know, and I think that some of the interventions that we talk about are actually meant to pull parents in together, right? Like, for example, one of the ones that we talk about early on is a baseball analogy for self-care. And, you know, in that one, I actually draw it out on the exam room paper, right? So first base is actually self-care. So the caregiver learning to take care of themselves so that they can be more available, you know, using the sort of analogy of the airplane where they said, put your own oxygen mask on before helping others. Second base is taking care of the people who support you. And I talk a lot about primary relationship between the caregivers in that and how you actually maintain that. And I use a kind of unfortunate example in that scenario. I had a family that came in for their kid's 5-year visit, and the parents were bickering with each other, but bickering in a way you could tell they didn't like each other very much. And I think that oftentimes as pediatricians, we kind of think that's not our business and we don't engage with that kind of behavior. But I actually asked them when the last time was that they went on a date, and they hadn't done any dates since before mom got pregnant. So they've gone 6 years without any relationship maintenance, which obviously isn't good for anybody, right? And so I talk about the value of actually maintaining that relationship with your co-parent, whoever that may be, as part of that. And that's early on, right? Like that's at the 1-month visit typically. Third base then, by the way, becomes taking care of your dependents, right? And I talk about how in Little League games, kids hit the ball and they run wherever they feel like. So, early on, parents are doing the Little League thing where they're running to third base a lot, but they got to figure out small ways to get the bases back in order to really score as parents. And so I think that, when we talk about trauma histories, we ask both parents, we actually ask parents to reflect on that and to reflect on how their parenting experiences were, even if the parent isn't there. Now, obviously, it's hard to get both co-parents to come into every visit, but we do try to engage them when we can. Our recommendations would say to screen both caregivers for peripartum mood disorders. I tend not to screen them both, but ask them both how they're doing emotionally. And I think that sort of a targeted question helps. When we start a visit with "How are you?" it's kind of a conversational non sequitur, but how are you doing emotionally gets really pointed. And I ask dads that when they're there so that they can understand that I care about their mental health as well. It's sort of a light touch again, and it's opportunistic when we can. We try.
Can I add one thing about that? I think we love the baseball analogy for sure. It's in the book. Another way that we go about this is through relational mapping and circle of support. And I think what happens, to Anne's point, is that we have kind of deferred to moms as primary caregivers. And unfortunately, the outcome of that then is that we dismiss other parents, co-parents, and beautiful intergenerational families where Grammies and grandpas and aunts and uncles are also part of the caregivers in a child's life. And we want all of them to be part of that child's life. So we do a brief intervention around circles of support, and it's really relational mapping. And if we look way back, one of my why early on was working with families that had children with complex medical needs. And when we studied what helped them feel like they could cope to having a child with complex medical needs, it was their support systems, their connected relationships. And one of the things that we found was that dads could not list anybody in their primary circle other than mom. So it becomes critical, in fact, that we ask other caregivers who their support systems are as well, because we all need, not just kids, but adults need the buffering mechanisms in their lives too. So I really appreciate that question, Anne.
And I think a part of it too, in terms of just getting both parents engaged, is there really has to be some value to both of them coming to the appointment, right? And so I think that the old way of doing well childcare doesn't necessarily meet that need, right? Like, am I going to take off work to show up to an appointment where they tell me to put my kid in a car seat and use a bike helmet? No. But when we start doing these relational health interventions early on at the newborn visit, the 2-week visit, the 1-month visit, when oftentimes both parents are there, I've seen a lot of pickup in the attendance of both parents at subsequent visits. And I have had families who come in who sit down and they say, "What are we talking about today?" Because they know that I'm going to talk about relational health stuff, and they're engaged and they want to hear it. But I think that's a big piece of the well child transformation, is that we have to actually make it valuable for both parents to be there.
That's a
Otherwise, they got
mindset.
work,
That's such a mindset shift, RJ, from the way many were trained, to really take the relational lens and realize that father-mother relational experiences with their kids are equally important, and important to our focused on their future family well-being and resilience. There's another question that I find interesting that Rob Meters asked. He said, I'm hearing you both speak about early relational health so eloquently, but I'm just curious why the book's title doesn't not reflect more about early relational health than trauma-informed care, although obviously that's important. Is there a sense that early relational health is not as widely accepted or understood? How did you wrestle with that labeling and titling? Because early relational health is throughout the book, and I had the same kind of question myself. Thoughts? What would you say?
Yeah, that's a great question. And I think that we needed the title to catch as many people as possible. And I think that when we lead with early relational health, a lot of clinicians think we're talking about mental health and they don't pick it up. And when we talk about trauma-informed care, that's gotten a little bit more traction in terms of something that most clinicians realize they need to do something about. And so it's strategic, I think, to put trauma first and early relational health second. But the Academy has just very recently in their policies started talking about how trauma-informed care is relational health care. And so I think that we're moving that dial so that we're kind of turning the attention away from trauma and into relational health promotion. It just wasn't there when we started writing the book. And so that's certainly when I go and talk about the book, I focus it on early relational health now, the presentations that I do. But I think at the time, I didn't want to have anybody who was in primary care think, oh, that must be for my integrated behavioral health provider and not for me.
Oh,
Yeah, if I can add something even more frank about that, I still, when I go out to do trainings, and I'm sure this is similar for you, Robert, if I ask how many of you are familiar with the ACEs study, we might have 30 to 40% of the room, even for people whose job we would think would be to know about adversity and trauma. And then when I ask about, do you know about the positive childhood experience study? Do you know about the impact of having those connected relationships? Even less know that. So I think sometimes we have to start with what is known, right? And part of being a trauma responsive environment is recognizing that trauma is pervasive, it's everywhere. And that way we can say, awesome, you know what? We have the antidote to that. It's connection and relational health. And we can really build then the underpinnings. My hope would be, and my passion is that every single person who's interacting with kids and families understands what trauma is, how it presents, and that they know that the dose response, the antidote to that is relational health. But I think to your question, Robert, we had to start with a more known entity and then kind of increase internal capacity about relational health.
Yeah, in reading the book, it's all about relational health activities, promotion, guidance, but and meeting the family where they're at, either with a degree of trauma that makes it required to connect and build relationships and protections, or those families that are eager to just be mindful of promoting their well-being at all levels that don't necessarily have as much history of trauma, but even still focusing relationally, and especially in this culture, is really so critical in the good work. There's a couple other questions in the chat I noted, and one was about residency training and the importance of how far this work is starting to be recognized in residency, because the future of pediatrics is focusing relationally and trauma-informed care and really promoting well-being. What are you experiencing? What are your thoughts?
I think it's definitely something that needs to be embedded into residency training. And, I'm not in a position where I could comment about how much residency training has changed. Certainly I'm unfortunately moving into the old guard, right? My residency was a long time ago. But, again, at the time it was very minimal. Again, 2 weeks of developmental behavioral pediatrics, and it was just insufficient. So I think that there is definitely a need to get residents the ability to hit the ground running when it comes to developmental health, behavioral health, and early relational health. I don't think we're there yet. It hasn't really filtered into core competencies from board certification perspective yet, at least not very strongly.
What I would say is that it is beginning to catch fire. I'm starting to get requests for grand rounds, for residency training partnerships, like with University of Washington State, rather. And so I'm really hopeful about that. The message is starting to get out there that relational health is really important. And I think the other thing about residency is when you can message hope, because there's so much hope when we talk about relational health, it feels so much more accessible and digestible. And so that's what I'm noticing about like organizations that are reaching out, including residency programs. It's like, oh, this is right in line with what we want to be doing as pediatricians, anticipatory guidance, right? And relational health just fits right in there with what you're already doing. So it's a natural fit, and we're starting to see that. But certainly for those of you that would like to see more of it, we encourage you to tell other people that that's where it should be.
Exactly. Why we're doing this webinar and continue to from our Nurture Connection network expanding and making visible all what we call bright spots in advancing other relational health and the various approaches that more and more people are doing, like you. Christina asks also in the chat about, love to hear how you think of strategies about engaging families, family engagement. And I take the twist of the more challenging families who, are a little harder to connect with. What are your strategies, RJ and Amy? But RJ, you first. How do you use a relational framing of engaging with families that are a little bit more not as connected or a little more standoff or distrusting? How do you
Yeah.
go about it?
Yeah, and I think the first is kind of within my own mindset, remembering that there are a lot of people who have good reasons not to trust the healthcare system. And so, I'm not going to force anything on a family. And I think about this in terms of any assessment tool that I use, that I'm not as interested in the answers as I am the culture change that comes along with this, right? So if I start talking about social drivers, for example, and the family isn't ready to talk about what's going on, I want to at least have them get the message that it's okay to do that when they choose, right? So that in our relationships with families, we can position ourselves as a trusted person, but it takes time for some people. Other than that, I think if there's specific subjects that are coming up, and most often, I talk about relational health with those families in the context of a behavior that they're worried about. And I think just sort of, asking open questions about what does this behavior mean to you, or what do you think this behavior means, so that we can kind of figure out where they are and then start guiding them towards the relational health answer towards that behavior, right? So, for example, like the mom that I talked about earlier, I think is a good example of that. It meant something very different to her. And she's, before we started talking about these sorts of things, she's a little bit prickly, standoffish kind of mom, right? And once I was able to kind of connect with her in terms of understanding what she was believing about the behavior, then I was able to make some inroads. But I think that we position ourselves as someone who is safe to talk to, but ultimately the family has to decide that they feel safe in that situation, right? So I'm not gonna force it, but I'm gonna keep myself open, and I'm gonna try to change the culture of practice every time that I see that family, so that they know that these are things that we can talk about. I think people still come into their pediatrician thinking that I'm here to get my shots or to get my throat swabbed or whatever, and they don't really know that relational health and developmental promotion and those sorts of things are part of our wheelhouse. And so it's kind of a slow, again, the 100 little conversations, sometimes it takes that many to get a family to engage, but they do eventually.
I really like that 100 little conversations over time, because it's like we say, not one bite of the apple. We often get multiple times that meet with similar families. That brings me to a question Christina Pease out of Seattle asks. How do you engage colleagues who aren't quite seeing things in this way? What are you discovering of your colleagues as they watch, listen, learn? What's that journey that each of you are experiencing?
I think it's kind of the same sort of thing, like any quality improvement project. We always talk about, you have your early adopters on the one end who are just going to race in and do it. We have our naysayers at the other end who are probably never going to do it, But we try to address what it is that's getting in their way. Like what is it? What does it mean to them if they try to implement this change, and kind of learn from them what it is? Everybody else kind of falls in when they see the value of it. I'm fortunate, I would say, that I work with a very progressive, creative, innovative practice. So like when we started asking parents about their adverse childhood experiences, just to understand their histories, it initially was going to be one of my partners and I, but when the other people in my pod heard what we were doing, they're all like, wait, I think we all need to do this. So it was actually a bigger group than we intended. And so it spread very quickly. And in my practice of 30 providers, only one really said no. So I've been very fortunate. I do think that other than that, it often comes down to figuring out where a provider's pain points are in their world. And for a lot of us right now, it's the mental health crisis that we're seeing in kids and adolescents. And so giving them some tools to start addressing and helping with something that's really on front of mind is the way in. And so I think that we've been able to talk about the relational health stuff from that sort of prevention thing. You're overwhelmed right now with anxiety and depression. Let's backtrack a little bit and look at what it would look like if we started talking about early relational health first, to try to narrow the pipeline of the kids that are having those sorts of relational health disturbances down the road. And that tends to land for people too. Amy, what do you think?
Well, I would just add, I think people come into the practice, this type of practice, in a couple of different ways. And you hear RJ and I we have a couple of mantras, if you will, that we keep going back to: 100 small doses, right? And the other one is, you're already doing this. And so for, kind of our late adopters or skeptical colleagues, you're already having hard conversations in primary care, right? You've been doing that the whole time you've been practicing. You're already providing anticipatory care and anticipatory guidance. You're already in there with the dyad. We're just giving you sometimes some scripts or approaches that might feel like you have, more collaboration, where you're allowing families to be experts in their past. After all, it's not surprising to them that they've experienced stress and trauma. They're living it right then. But to ask about it really allows that relationship, first of all, with your primary care doctor to really bloom and flourish. We don't get negative feedback that having caring professionals, is a barrier to care. In fact, what RJ and I hear over and over again is that it allows people to feel like, oh, this is really meeting my needs, my needs, my psychosocial, biological needs that I come into care with. And so I think that's an important thing to note in terms of late adopters. And then what I notice is there's no malintent, right? Like, once we begin talking about how relationships and recognizing adversity shifts the relationship, there's so much, and I'm not just talking about the pediatrician, but the entire medical practice begins to go, oh, I just didn't know that angry parent that came in and they're upset with the front office staff. They weren't doing that to just throw a wrench in my day or be difficult. They were probably really stressed about the 2 buses that they had to take to get there, and now they're running late for their appointment. And so I think as we increase awareness, what we're also doing is we're allowing families to feel seen and honored in terms of all of the larger context that they're bringing into primary care. And it's like Maya Angelou says, right? Once we know better, we do better. And that's the big shift that we begin to see, even with folks who are a little bit late adopters or skeptical, right? That we begin to provide some case scenario and they're like, oh, I didn't understand it that way before. And often for them, they're bringing their own stress and trauma in there. And once we provide those connection points, they're starting to feel better in their workplace as well.
And I think that gets into provider burnout a little bit. We certainly have this problem in primary care that people are really feeling burned out. One of the antidotes to that is really meaningful work. And so once people start doing these interventions, they feel better connected to their patients and families. Their oxytocin levels are starting to go up, right? It's an anti-burnout thing to really start working on building the relational health. It feels like we're doing something useful.
It's the number one qualitative outcome that we had when we first presented at the AAP was decreased physician burnout by approaching this a different way.
Yeah, 100%.
I hope you're all watching in the audience the chat conversation. It's fascinating. One asked the question about, does the book address and provide strategies for a whole clinic changes that can reflect both trauma-informed and relational health? What have you noticed and do you attend to that question?
The short answer is yes. It is not just for the provider, it's for the whole clinic. RJ lays out what we call the nuts and bolts section. I address early barriers and what trauma-informed look like. Part of what we haven't mentioned yet, Dave, is that our book is a back and forth conversation between RJ and I that I think people will really like. But we're not just looking at people who are, PCPs, MAs. We're talking about your billing and coding department, your front office staff. To be trauma responsive and relational means front to back, top to bottom. And so we have strategies in there to help build that from the beginning.
And I think too that the trauma-informed training can't be a one and done. This field is changing very quickly. We also need to kind of troubleshoot where things are going well and where things are not going well. What are the resources that are working and not working and so forth. And so there's a little bit of a maintenance map in terms of once you've kind of gotten everybody to the point where they understand and are aware of trauma, how do you keep that going so that you're really keeping up with the literature, but also keeping up with troubleshooting in the office. And I think that one of the very powerful strategies that we talk about in the book that I think is important for everybody to think about is really getting your families engaged in the process as well. When I hand an assessment tool out to a family, I know what I think about it and I know what I'm trying to get out of it, but how does the family see that and how do they respond to it and how can we ask those questions differently? For example, when we started talking about social drivers of health screenings in the practice, there was a very strong from our family advisory group, we might not want to talk about that in front of our kids. Can you give us a way to talk about it later or at a more appropriate time, which is just a great note to put on these kinds of assessment tools, right? Like if you're talking about, I can't get food on the table with a 5-year-old in the room, the 5-year-old's going to understand what's going on. They're going to, perhaps read into their parents' fear and anxiety. But if we set it up so that we can talk to them by phone in a few days and get them the resources or whatever, but that all came out of family feedback. And so I really think that getting families involved is an important part of that culture change.
I want to come back to that, but I wanted to attend to a question that Rob asked about, are there qualitative or quantitative studies about that early relational health prevents burnout? Do we know?
That's what I was alluding to just a moment ago. And so we published that in an AAP poster session several years ago about the qualitative research around burnout. And then we reiterate that in the book as well.
Wonderful. But back, RJ, to the comment about engaging families. And about, you mentioned a family advisory group. Can you talk about how that likewise has helped advance the relational health practice activity, what the parent voice, contribution, partnership, co-development process? Because that's so much about the early relational health work is really the learning and the partnering and the learning with families along that journey of change. How has that informed your work?
Yeah, so it's I think a transformational act for a practice to do that. And I think that a lot of providers are a little bit nervous about pulling back the curtain and letting people see how messy the practice may be behind the scenes. But if you think about parents and families having the same goals as we do, best health care possible for their kids, that their kids have the best outcomes, then they want to figure out how to partner with us to fix that, right? And so in terms of our journey, we started with, when we were doing some learning collaboratives around medical home and around trauma-informed care, we recruited a parent partner to come with us to those learning sessions. We did it through Johns Hopkins initially. And so that the parent could hear what we were hearing and inform how we actually implement anything in practice. We moved then to having parents on our quality improvement committee so that they were informing us again as we went along. We do surveys, both mini and maxi surveys, to kind of get the parent feedback about how these pieces are going. But now we have a full family advisory board. So we have a dozen parents from our different sites that have an opportunity to give feedback on pretty much anything that the clinic is doing. to shape how we're actually approaching them and how we're engaging them. And it's been amazing. The feedback that we get from the families are just things we never would have thought of. And just something that I think every practice needs to strongly invest in. You can start small again, like we did with just having like a parent come in for a project kind of thing, and then move from there. That's how we sort of evolved the process. But again, it is invaluable, the information that you get from families.
And can I offer too, Dave, that I think, RJ and I have been doing this work, boots on the ground in our practices for a long time. Parents inherently inform our practices because we're watching and learning every day what feels resonant to them. And they want to talk about how relationships are going. They come to primary care spaces as a safe haven. Your physician is often your first line of help and resource and input. But then I also think about, other pediatric spaces. Somebody had asked a question in the chat about Head Start and early Head Start. We know naturally that parents are partners and that their feedback guides the work that we do and how we approach relational health. And so I think also just being humble about parent feedback has been really transformative for both of us.
Yeah, I was going to say everything we do within Nurture Connection as well as advancing early relational health is in the co-development, the partnering with families to what's meaningful for them, and that kind of shared learning and growth and change, and that parents are the experts of themselves and their kids, and we value and want to always value and recommend and encourage and support in that kind of way with families. Listen, we're coming towards the end of our time, and first of all, it's been great, to be together. And I wanted to first ask for each of you to make comments. Give me one key point that you'd like the audience to take away. And then each of you get a chance to do it. Amy, what would you say is the one thing you'd like as a takeaway from this audience?
You're already doing it. Keep doing what you're doing and build from there. Don't be afraid to be that first fan, that first champion in your office that says, as someone said to me, this is the most important medicine.
Absolutely. And RJ?
Just the reminder that it's 100 little conversations. It's not building a relationship in a single day. It is a longitudinal process. So doing little bits, little bites, families love it, and you will eventually get to the point of having caregiver child relationships that are strengthened. And absolutely, you're already doing this. So play to your strengths and figure out how to make your conversations relationally based, and your parents will thrive, your children will thrive.
So Amy and RJ, this has been great to be together. I'm an absolute champion of the beauty of the experience of reading this book and what it can do for your heart and your soul as a clinician, but also for families themselves. And they can't say it, but I can. The book's available at the AAP. It's also available, amazingly, as a Kindle book for those that care, and then also on Amazon. So I encourage you to purchase the book, spend time reading through it, and reflecting on the journey that they talk about in their own growth towards early relational health in their practices, but also what it means to you, because there's a lot of reflective moments that are carried in the book itself. So thanks again for those of you attending, and share with others, connect with us at Nurture Connection, and follow along with us over time. But again, thanks for spending time with us today, and good Thanksgiving to you and holidays. Thanks so much.